Sally, Ellen, and Hesong. Okay, Ellen, I know you're in Korea, so let's start with you. Any updates?
Good morning, Chae. So I guess I'm still kind of in the update stage, but I got contact with Dr. Isa and Dr. Chui about the pathomics project.
Yeah.
And so he'd given me a list of articles related to the project, and I just wanted to kind of confirm with you what I'm supposed to be doing with that because they told me that I'm supposed to be updating the current manuscript that has been written so far.
Mhm.
Um, is that kind of what I should be doing regarding the manuscript? Uh,
It's almost writing from scratch. I think they wrote some. I don't know how much they wrote. They never showed me.
okay.
So whatever they've written so far, your job
Mhm.
is to what is the most recent findings on this topic and update that in the manuscript.
The manuscript they actually sent me kind of seems like a complete uh, manuscript, so I was kind of confused of how I'm supposed to actually update it. I could actually show you
Yeah, yeah, yeah.
what.
Mhm.
Um, Give me 1 second. Uh, I will share the screen. Um, can you see it, Dr. J?
Yes.
Okay. Yes. So they had actually sent me a 20-page document. It seemed already in the final stages of writing. And so I was just assuming that maybe I'm supposed to be reading the new articles and then maybe adding in that kind of information into the whole manuscript.
Mhm. Can you scroll down?
Yeah.
Okay. Yeah. So yeah, yeah, scroll down.
Okay. Um,
So
Additional.
applications for immune biomarkers. So this is just looking at H&E slide. Can you predict what biomarkers are positive?
Mhm.
Next, go
Yeah.
down.
And then going down, prediction of
Yeah.
immunotherapy,
Mhm.
uh, prediction of
Yeah.
toxicities, exploring cancer biology, and then challenges, the
Yeah.
current landscape.
Yeah. Yeah.
Scale archives, current challenges.
Yeah. Yeah. It's almost written up. I don't know why they stopped. Um, I don't know why it wasn't. Do you know if it was ever submitted?
I do not think it was. Dr.
Okay.
Yizu told me that when she kind of passed it on to Dr. Juhi, I talked to Dr. Juhi and she said she didn't really touch anything about it. And so I was referring back to Dr. Yizu and she said that she also didn't have much time to touch it. So
Uh,
yeah. Um, and so the articles that they had actually sent me were more recent ones, basically from 22 to 21. Which I do believe are not included currently on the list of references here. Uh,
yeah. So, so is Dr. Horyun the first author of this paper?
uh, yes, I do believe so. Yes.
Okay. So I believe he and Dr. Yeser did a lot of work.
Hmm.
I don't know what happened, why they didn't submit this. because
Okay.
since they wrote this, a lot of papers came out. So it's not only the
Yes.
papers that you got, but you have to do
Mm-hmm.
your own search with the keywords and find out
Mm-hmm.
those new publications that needs to be added
Mm-hmm.
publication, and you just update what you found. That's it.
Okay. Okay. I guess I can try reaching out to these two people, kind of see what was kind of really remaining about what I should have been doing or
You can reach out, but I
Mhm.
don't expect much. They're super busy and I don't think
Okay.
they're helpful, but you can reach out. They're the first author. They should know what's going on.
Hmm. Okay. Okay, I'll do that this week. And then Liam had also mentioned that you're considering this to submit to the ASCO, um, the abstract, I believe. Um,
So that's only if you can do meta-analysis. You can't submit app review papers to ASCO.
hmm
So if you can do meta-analysis, meaning
hmm
for the immunotherapy prediction, you're gonna
hmm
have a biomarker, AI biomarker, and you're gonna have a outcome like hazard ratio. What's the prediction? And
hmm
if you can pull that data, and
hmm
in order to do that, you need to know how to do meta-analysis, and you can get help from any of the statisticians that
Okay.
get some help. Uh, but so it's not just the Lunit, but other people are doing H&E slide based prediction for immunotherapy response.
hmm
So I know their technology is a little bit different, but if you can pull that, do a meta-analysis and
hmm
show it's exactly what Dr. Juhi did in her paper. Like if you can predict um and then Dr. Juhi's paper, I think it's in the preprint. And Liam,
Okay.
you can send Ellen Dr. Juhi Cho's paper so that it's preprint. It's online, but it's not accepted in the journal yet, but it's preprint available online at Lancet.
Okay.
Um, so yeah, do some background reading and see if you
hmm
can do meta-analysis. If you can, then you
hmm
can do abstract for ASCO. If not, just finish the review paper by updating the recent articles.
Okay. All right. I will have to get back to you on that then,
Yeah,
whether or not I have to try to figure out the meta analysis.
yeah.
Um, uh,
Anything else?
okay. No, that's basically it on my part. Yeah, just trying to catch up on the whole background information and then, yeah, figuring out what to do. So now that I know, I'll probably try to get work on that for this week.
Yeah, yeah, and try to get as much help from Dr. Horion. Maybe he has some time. I don't know. He's doing hospitalist job, so I don't know how available he is. So
Okay, I'll try reaching out first and see what I
yeah,
can kind
but
of do
don't
with
wait
them.
on anybody. You
Hmm.
are you are in charge of finishing it, and hopefully you get it done before you start your residency. This is for like a full-time job where I think expected time to finish this. I would say if you do it full time, 2 months.
hmm
It takes 2 months to finish this. Uh,
Okay.
okay.
All right. Yeah. I'll try my best to finish it by then.
Okay.
Okay. Yeah.
Anything else? Is that
No, that's it. That's it for
okay?
me.
Okay.
Yep.
Great. Great. All right. Who do we have here? Richard, do you have any update?
Hey, yeah. I have a few updates about the clinical trial, the
Yeah.
EVOP for ACC. So I sent the draft over to Lunit. They haven't gotten back yet, but they're reading it over right now, and they're gonna tell me like who to include and like what their thoughts are on it. I emailed a couple of journals. So JITC emailed back saying I should send it to BMJ Oncology.
Hmm.
So I emailed them and they were willing to get the or like look over the manuscript. So they want us to submit to BMJ Oncology. I wanted to see what your thoughts were on that.
BMJ Oncology.
Yeah, it's pretty new. They don't have like an impact factor yet, but
Oh,
they
really?
they have had clinical trials before. They had one from NISCON. It was like Nivo for salivary gland cancers, a phase 2 trial that they published last year. Um,
Oh,
yeah, so it's an option, I guess, but
is, is that a open access journal?
um,
Can you share this screen? Can you show me the journal website?
yeah, here, let me share. Um, oh yeah, it is open access. Yeah.
BMJ Oncology. So who recommended this, you said?
The JITC editor.
Really?
Yeah.
How is it related? BMJ and JITC. Hmm.
I think they're both BMJ journals, but that's about it.
Oh. Hmm. You know, the open access, they're expensive, but they also have pretty high impact factor.
Hmm.
Uh, as and later. I mean, so so JITC didn't review it. Didn't. They just said this is a better journal.
Yeah, they didn't review what they read it. They said the editors recommend submitting to BMJ Oncology.
Hmm.
Yeah.
Okay, let's do it.
Okay. Okay. Um, in which case they have like a kind of like a specific thing where they want like a brief intro that I wrote here, and I wanted to see if you approve of it, kind of like a summary before submitting there.
Mm-mm-mm. Mm. The frame shift mutations, that could be really random. We don't know if that's really a meaningful contribution or not. It's just a
Okay.
finding.
Yeah.
I would take that out. Mm. Reliably results in durable. I would take reliably.
Okay.
Just
Uh,
soften it as much as you can. It's not
mhm.
a home run paper, so
Yeah.
yeah, it's okay.
Okay, cool. Thank you. And then one last thing. So down here, I added a few sentences about so we were trying to describe why the patients who
Mhm.
had progressive disease had higher TIL scores than
Uh-huh.
patients with standard disease. And so I was looking into like CTLA4 inhibition and how that could play into um, why low TIL score patients did better. I wrote this like purple part here, wondering if what you thought about that.
Hmm. I think it makes sense, you know.
Okay, cool.
Yeah, yeah.
Just making sure I wasn't writing anything crazy in here.
No, no. The idea is CTLA4 is it's more recruiter, so the
Yeah.
baseline may be still low. Yeah.
Okay.
Maybe I don't know. I know this is melanoma.
Mm-hmm.
Uh, did you find anything like this outside melanoma?
Um, Nothing outside of melanoma. I saw something brief about a GI cancer too, but um, it didn't say exactly kind of what I wrote down here. It was kind of tangential.
Hmm. Okay, just curious. Well, I give you homework. Maybe look further into in lung cancer. You know, the biological role of CTLA4. Has there been like, despite low T cell infiltration pre-treatment, that it did actually recruit T cells? These are all theoretical roles that we describe, but has there been any study showing it? It could be outside lung too, but mainly in lung or outside. Can you look for more evidence there?
Okay, yeah.
Not that you need that for this paper, but for your own learning, I think it's a very, very important topic.
Okay, yeah. And if I find something, I can cite it here too.
Of
Uh,
course.
okay, sounds good. Um, so I'll do that while waiting for Luna to get back, and then I'll send out the full version to the authors as soon as I can. And then
Mm.
one more thing. So the statistician, Irene,
Yeah.
I realized I didn't put her in the authors. Where do you think she should kind of like go in here?
Statistician. Okay.
Yeah.
You can in front of Maria Masango.
Okay.
I think Maria is in. Do you know their other contexts? Maria's in either Abby or Estelas or.
Yeah, yeah, I think she's at Celos. I emailed them earlier from the
Okay.
abstract. So
And Mark and Vicky is in City of Hope.
yeah. And then
That
peace.
was here. Yeah.
Cool. Yeah, that's all I had.
Okay. Okay. Very good. And any update on the sample? What did we decide to do about the samples?
Oh, right. So the samples over at U Chicago, the positive responder, they lost the block,
Mm,
so they just don't know where it went.
mm,
And then the other two, they don't have. One of them, they said that they don't have enough of the sample,
mm,
to like give us any H&E slides, so they can't do that. The other one, they said that they were a referral. They don't know where the original sample came from, but they don't have like the actual sample itself. So
mm.
they didn't have any of it at U Chicago, so I don't know what to do about that. I don't think we can do anything really.
I see.
Yeah.
So, okay. Okay. What was the one that was sent to us? There was one.
That was from Oregon. That was a person
Yeah,
who I thought was the positive responder, but they were not.
they were
They were,
not.
yeah, they were. I mixed it up.
Oh, okay, okay, okay.
Yeah,
Well, at least you tried. Okay.
yeah,
Yeah. This is why all these trials has to be, it's better that we do a prospective tissue collection at the
yeah.
time of enrollment. Let's get what we can. So
Hmm.
yeah, yeah. So that's why, the sample studies are so hard. Okay, very good. So let's get that out. This is the adenoid cystic.
Hmm.
Um, are you working with Dean on the other papers?
No, I wanted to get this one kind of like done and then work on those, but uh,
Okay.
I think I should submit it soon because I'm just waiting for Luna to get back and then I'll submit. So
Uh-huh, uh-huh.
or like email the authors and then submit. So
Yeah, but did you get everything from Dean?
Yeah, I got the drafts of the manuscripts from him.
And he was working on both Nivo metformin and Nivo veliparib.
Yeah, both
Yeah,
of
yeah,
them.
yeah. So I don't know. I think he was coming to our lab meeting. I don't see him anymore. Maybe
Yeah.
busy, but you can definitely take over and publish it together.
Okay.
Yeah, these are very similar projects. So
Okay.
yeah, so once this is done, yeah, you can keep working on the two more
Mhm.
papers.
Yeah. Sounds good.
Okay, very good. Thank you, Richard. Okay. You see. Brandon, do you have any updates on what you've been doing? I know you in school.
Yeah, I have a couple of updates. Just like a couple of quick ones. I'm still waiting
Oh,
to hear from Will about the DW project. We're just trying to figure out which spreadsheets I should look into in the H drive. And then I should be meeting with Sally sometime relatively soon about the Imagining AI project. Um, and then I worked with Dr. Liam about like the lung transplant project, and so I have a presentation. Um, I can share
uh-huh.
my screen.
So Brandon's been working with me, Dr. Wu, and Oranus the on the metastasectomy,
Okay.
and have we've made some progress, and we're collecting information, aiming for a umbrella meta-analysis.
Uh-huh.
I think we can give you more details on the project itself when Dr. Wu joins. And
Uh-huh.
Uranus also can give us an update then, I think. And Brandon also has this, and then,
Do you know what time Dr. Wu is?
well, actually, that's a good question. He is supposed to join at 10, but then he's not, I assume he told you he's not able to join,
Uh,
um, well, he's not able to come in today in person because all the schools are closed, so he has to
uh,
stay home with the kids. I'll message him to check. And then Brandon also has the presentation from before on the colorectal cancer liver transplantation.
uh-huh. Okay. But yeah, let Dr. Wu know he can come into the Zoom meeting. I was wondering we should wait for him or not.
I think the colorectal, this presentation, I don't think we have to wait for him, but then for the
And it's that
lung
yeah.
metastasectomies, I think we should wait for him.
Oh, okay. Go ahead, Brendan.
Okay, so can you see my screen?
Yeah.
Okay, so I went deeper into this paper that you told me to look into, just like generally about like what characteristics these patients have that qualify for liver transplant to treat their colorectal cancer. So this was done for a pretty long time. So they looked into CRLM patients, and they looked into liver transplant as a potential treatment for them. And so this is kind of like the methodology of the study. So this is a prospective non-randomized control trial. And to identify the patients, they actually used three main things that they mentioned to use as like prognostic like factors to determine which patients would more likely survive or not. So one thing was the PET MTV. So the before the transplant procedure, they basically used PET and combined it with CT to rule out any like extrahepatic metastases to look into the MTV for all the liver metastases, and they established a cutoff value of 70 centimeters. And they also used another factor called the Fong clinical risk score, which basically is like a numerical score from 0 to 5. And they like you would get a point for the score, whether like it follows like there's the specific criteria, which is like less than 12 months from the diagnosis of the primary tumor to liver metastases, largest lesion size exceeding 5 centimeters. So basically, this score, higher the value, the I guess the worse the prognosis of like like I guess like a worse chance of the prognosis of the patient. And that's very similar to the Oslo score as well. That's what they use. That one from 0 to 4. They're pretty similar in my opinion in terms of like what like the scoring is, like what criteria it is. But then there's some like differences in terms of like values, like for example, like the size of the largest liver lesion being greater than or equal to 5.5 centimeters. But they used the Oslo score as well, and they mentioned that these three scores are the main things to determine prognostic significance.
So do you have to have higher score to be eligible?
No, they basically tested all these patients who have colorectal cancer and that are eligible for a liver transplant, but they use these like to kind of, I guess, like identify patients, like to see like basically they tested people with like they determined that people with like lower FCRS scores or lower Oslo scores, they would have better prognosis.
No, I'm a little confused. This is patient selection criteria, correct?
Yes.
And you're saying prognostic scores. But I'm not interested in prognostic scores. I'm interested in what do you need to select patient? What makes patient eligible? Higher score, lower score?
Um, they 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 basic they didn't like I guess like patient selection is the wrong wording. I guess they use this to identify like I guess like characterize all the patients that they use. But
So
these are like
I don't understand. So in prognosis, when you get liver transplant, are these scores used to predict how well they do after transplant? Or
yes.
are these just the regular, just, you know, liver candidates that are not going to do well?
They use this to determine like all these patients had like liver transplant for their colorectal cancer, but then they use this to identify like let's say for example their based on the FCRF score, their largest lesion was over like it was like less than like 5 centimeters, for example, then they wouldn't get like a point for their FCRS. But these are all patients that had a liver transplant.
So out of patients who get liver transplant, the lower the tumor burden or the less advanced the cancer was, they're more likely to do well in terms of survival or in terms of cancer recurrence.
I did a
What
quick search and it seems like it's about recurrence. It's usually used in patients who receive liver resection, and then you use a score to calculate the recurrence risk among patients with colorectal cancer with liver mets after hepatic resection.
This is not patient selection, first of all. Second of all, this is predicting the cancer recurrence. These scores. That's true, right?
Yes.
Okay.
Yeah.
So when you just presented, that message didn't get across.
Yeah,
You
I'm
understand?
sorry. Yeah, the
Yeah.
wording I think was just not right. So
Okay. Thanks, Hetong. Yeah, go ahead.
okay. And so jumping to the results section of it, they used the Kaplan-Meier method to estimate like survival. Um, they also used the reverse Kaplan-Meier method to check for like for follow-up with the patient. And so the total amount of patients that they looked into was 72. But then actually 61 of those patients underwent liver transplant in the hospital. So these were just basically like the reasons why they didn't go through like 11 of those patients didn't get liver transplant. These were like some of the reasons, like basically due to the metastatic disease, they determined that the frozen section examination of highway lymph nodes at the time of laparotomy.
You
And
can move
then
on to
also,
the next slide.
okay. And so this was like the first table. This is just generally like the characteristics of the patients previous to the treatment. Some things that were caught my eye to me, or at least this one, the primary YPT3. Um, so then it was just like a later stage of the colorectal cancer, and then like a couple of other things like they had like these types of chemotherapy, but like a lot of these like chemotherapy or drugs are used as a treatment of colorectal cancer, as well as like some of them are used as like a combination, um, like like the 5-FU and then the irinotecan. Those are combination drug. Um, so these were just general characteristics. And so this is the first figure that they showed. They had a lot of different figures for this study. I on the side here, I wrote out all like the numbers because they didn't have like a table for it. I couldn't find one on the study, so I wrote out like basically the numbers that they wrote in their text that I thought were pretty significant and related to these figures. So basically, according to like 1A, most patients with colorectal cancer will have a disease relapse after liver transplant and a short disease-free survival with a median of approximately like 12 months. However, like according to like figure 1C, patients with like CRLM had a long overall survival time after reoccurrence that in some was like 10 years. As you can as well as you can see, like the overall survival was like 50 for 5-year overall survival was like 50.4%, which was relatively long. Um, so that's based on these figures, just like disease-free survival, overall survival, and survival after relapse. And this is the second figure that they mentioned. There was also a lot on this one. Like
Brandon,
they talked
sorry,
about like
can you zoom in? This slide is kind of small. It's hard to read.
You can make it a presentation mode.
oh
Also, when you guys present, this is what I want you guys to do. It's fine to make it in the PowerPoint, but you can make that into Google Slide. Or you can just work on it on the Google Slide, and you can make everybody editor and share the link in our chat room so everyone can have access to it without even downloading it. You will just have it in your Google Slide. So once you are done, Brandon, and everyone who's gonna do Journal Club, I want you to make it into Google Slide and make that shareable by making everybody editor. And then when I say everybody, it doesn't mean you put our emails there. Just go to the share section and make give everybody editor access. And then you can share that link in the chat room so everyone can look at it even after the presentation. Okay. Well, in the chat room as well as the messenger. Okay, so that people can look at it. Okay.
okay, sounds good. I'll do that after the meeting as well. Um, and then just like these figures, are you guys able to see the figures?
Yeah.
Okay, so according to like figure 2A, that one's referring to the Oslo score. And then in the text, they said from like with patients with like scores that are 0 to 2, they had a median overall survival of 92 months and a 5-year overall survival of 63.4% and a 10-year overall survival of 45.7%. And then compared to patients with also scores of like a higher score, like 3 to 4, they had a lower median overall survival rate of 24.8. Their 5-year overall survival is lower, 8.3, and their 10 years overall survival is also lower to 0%. That just shows like higher the Osler scored, the lower the chance of overall survival. And then looking into like figure 2B, that one's referring to like the size of the lesion. Basically, that one also says um, like greater the tumor size, like the lower the overall survival.
You can go to the
And then
next
figure
slide.
2C,
Brandon, you can go to the next slide.
okay.
You don't have to read everything.
Okay. This one also is another figure. I also wrote the text on the slide as well. But yeah.
I mean, what it's saying is the higher the disease burden,
Mm-hmm.
the higher the risk of disease coming back and die from it. It's overall survival. Location of the primary tumor is really interesting. Right side versus left side. What is the theory behind it? Is left
Uh,
side bigger tumor burden usually?
they actually, I think it was more I was for that part I was more confused because they didn't specifically talk about like the left side, right side. They were more talking about like the types of cancer or like the location where it's talking about the primary tumor is starting in the ascending colon, which would be on the right side. So it does like I guess that kind of relates to this uh graph right here, the right side has a lower overall survival, a median overall survival. So I think that's what they were showing, but they didn't specifically like talk about the left and right side in the text when I read it.
Hmm. So ascending the right side. So right side ascending colon has a higher rate of maybe distant metastasis, something like that. So left goes more downward, right side more goes upward. Okay, I
Like
think
yeah, just based on the number too, it just says like the median overall survival for the ascending colon was 17.9. And the median the 5-year overall survival is 10%, but then compared to like more distal primary cancers.
I think it has more to do with the fact that left-sided colorectal cancers are more easily detected by the digital rectal exam or the colonoscopy. You have more symptoms like obstructive symptoms, but right side, it's usually like patients usually come with like anemia, and then like they somehow incidentally get detected, and so they just usually get diagnosed at a later stage. So I feel like that has more to do with like this poor prognosis.
That makes sense. So maybe right side gets diagnosed at a more advanced stage than left side, and
Yes.
that leads to this outcome. I think that makes sense. That makes sense.
And that also partially explains why there are more cases of left-sided colorectal cancer, and it's because they present with symptoms, they get detected easily by screening.
There is difference in MSI high as well. I think right side it has higher MSI high. Is that true? Can anyone look into it? And there's some biology difference too, apart from the presentation difference. I think there's like a till difference between right and left side. colon cancer?
For MSI, there definitely is a tendency for the right-sided colorectal cancer to have like a higher MSI.
MSI,
Yeah,
right?
yeah. Not
Yeah.
sure about to
So the right side colon has always poor prognosis, lower survival rate than left side. Yeah, I think MSI high and then TIL as well. There's some so left side. So I have an article here. I'll just read it to you. So left side TIL was not associated with anything, but only in the right side. The higher the TIL, the better the prognosis. Yeah, I think that's sort of the nature of the right-sided colon cancer. Okay, move on. Next.
This was another table that they just generally showed. This just shows like prognostic factors that could be used to like that they could use to select patients that could be very good for liver transplant. So these are just like the general characteristics, like lower Oslo score, lower FCRS score, and stuff like that. This was just mentioned in the studies, like the limitations and solutions to things in the study. Just like limitation was they just have a scarcity of donor grafts, and some of those solutions were just like extend the criteria so they have more options, as well as like this. They mentioned something really interesting that I kind of looked into, which was called the rapid technique, which is like to perform like a hepatectomy. And kind of like resecting parts of the liver, and then they would resect like the donors, or they would that person would receive the donor segments of the liver, but then like once like they increase in size, um, they also resect another portion of the liver, and so then they have more donor grafts. So I thought that was an interesting technique. This table was not like shown in the study. This one was personally, I made it because I was like, there should be like something easier to show which types of factors are like just like I guess like kind of made a table so it's just easier to see which factors have like a worse prognosis, which ones have better. Um, so like for example, like the one that we mentioned, like the primary tumor in the ascending colon, that one had a really low overall survival. Um, but then, yeah, these are just generally like negative predictive factors. Just like the conclusion, like again, like lower the Oslo score, lower the FCRF score, just like better survival. Um, but yeah, that's just generally the study.
Okay, good. So go back to the very first Kaplan-Meier curve. Yeah. So what you need to remember is in 2 years, 80% will have cancer come back. Most of liver transplant for liver metastasis for colorectal cancer, there's a median overall survival close to 5 years, at best. If they relapse, 50% will die less than 2 years. So this is the current standard of care. This is kind of our benchmark for the lung transplant. So remember these figures. You can argue, oh, they're gonna die anyway. Most people relapse, 80% will relapse less than 2 years. while we're still doing liver transplant as a standard of care. That's kind of the benchmark. If the lung can do as good as this, I think I think there's a case to make. So it's not like we're curing them. They're 11, 10 years out. Most of them are alive. No, it's far from that. I guess teasing out who's dying from recurrence, who's dying from rejection, is probably the next step. But here this is more focused on disease-free survival, overall survival. Yeah. Okay, but anyway, it's good to have the notion that it is really a metastatic disease. And so Brenda, while you're looking at this, let me ask you two questions. One, when they recur after liver transplant, are they recurring inside the liver or outside the liver? Is there an article that addressed that question? So that's number one. And what's the percentage? And what is the timeline? Do most of them recur inside the donor liver? Or is it really the distant metastasis? And maybe that's different for right-sided or left-sided colorectal cancer. What are the predictor of that? Extrahepatic versus intrahepatic recurrence. The next question is what I just said. Cause of death after liver transplant. Is it because of the cancer recurrence? Is that the major reason? Or is it the organ rejection or infection due to immune suppression? So we have that data we've looked at in our lung cancer transplant. So you can read those papers written by Dr. Jian Li, and Liam can send those paper to you. But in liver transplant world, what is the cause of death? Because it's not written here, right? So
Yeah,
that's your next question.
yeah, so like whether like if it's like due to graft failure or stuff like that.
And that may be different year 1, year 2, year 3. But at least we should be able to know if cancer is the major cause or not, right?
Mhm.
And I'll give you a third question. Lung rejection rate and liver rejection rates are very different. If you can compare them and show us convincingly they are very different, that would be great.
So ideally like have like a number like percentage would be good.
Yeah. And then maybe break it down by the timeline too.
Mm.
Okay. Anything else?
Just like
We'll wait for Dr. Wu for the metastatectomy presentation, okay?
okay, sounds good. Yeah,
Yeah.
I just like read 2 papers about double lung transplant. But
You
then
have
Dr.
Oh, you have more for the lung transplant?
Like I read 2 papers about double lung transplant that Dr. Leon told me to look
Okay,
into,
yeah. Show it to me. That's okay then.
but
But these are the journals we published with Dr. Chian. So Dr. Wonjun Lee, he already presented on those.
Oh, okay. Then you don't
Yeah.
need.
We were only looking into the question of whether or not we had data on the differences between cancer versus non-cancerous indication.
Uh-huh.
Hey, Aranos, you're on mute. So yeah, the question was cancer versus non-cancerous indications. Was there a difference in
Yeah.
PTM or graft failure? We actually don't
Right.
have the data on that.
So we don't have the data on that?
No, we don't.
Okay. So the next question is, with the data set that we have, can we look into that?
Yeah, I think that will be a question for Dr. Chian. Because the PTM paper was only with non-cancerous DLT.
So yeah, so okay, so we never looked at that. Okay. So there's UNOS data and there's the international data. There's
Mhm.
two data set. So the question is, in those data set, if I don't know how well PTM is documented, we should look at lung cancer indication versus other, and look at the PTM landscape.
Mm. Yeah.
So I think Dr. Wu can look at that question along with the whole team. Is that like, does that sound like a plan? What do you think?
Yes. We'll look into it. I do. My recollection is that the data set didn't have that information, but I think we can double check
Lung
it.
cancer specifically, right? As the
Yeah.
indication for lung transplant?
It doesn't have to be lung cancer. Any malignancy will do.
Yeah, there is a general like indication, and it was like malignancy.
Right.
And Dr. Chian asked me once, like, has like BAC ever been like an indication for lung transplant? And we looked at it, and the sample size was too small. But that was like BAC specifically. And so if you look at lung like cancer overall, then maybe there is something.
Oh, I see. I see.
I can look into that with my new updated database.
Yeah, yeah. Why don't you do that? And because if you look at Dr. Jian's paper that looked at lung indication, lung transplant, lung cancer indication, lung transplant, I believe there were still, was it, I can't remember how many, was it around 50 to 100? Something like that? Do you remember, Hazel?
The thing is, I asked her about this because I could not find like specific like lung cancer as indication for lung transplant. I'm not sure how this. I can show you the raw data. Like you just can't find that data, and so I'm not sure if she made like an assumption or. Yeah, I just don't know.
Hmm. Okay. Now that Dr. Wu is here, how about you and Dr. Wu interrogate the data to see what's the best way to, find those patients. So the question we're asking is, how can we best identify people who got double lung transplant for cancer indication? And I believe there are mostly lung cancer. I don't think they did any non-lung cancer metastatic transplant. So yeah, if you can find those patients, and I know it's awfully small group of patients, but and then just compare the it doesn't have to be lung cancer, but any post-transplant malignancy, it's good to break down by subtype. But if you can look at that and compare that to non-lung cancer indication double lung transplant, I think that's something that needs to be done. So, for some reason, I thought that was done, but it was never done. So, okay.
Sorry, I should correct myself. So there is BAC as indication, but no like other types of lung cancer. But yeah, I'll look at it once
Okay.
again. It's not difficult to find that.
Okay. Liam, anything else?
Yeah. So that was the colorectal cancer, and since Dr. Wu's here, I think we can proceed with our metastasectomy project.
Okay.
Dr. Wu has been kind of helping us in leading this. He has a lot of experience here, and we have a consensus paper on lung metastasectomies, and surprisingly, there's actually a lot more data out there than we had I had anticipated, and pretty good data too. So
Mm.
Rana's prepared this paper for presentation, so I think she can
Okay.
go next, and then Dr. will give you the overall update on the project itself.
Okay, let's go.
Um, can you guys see my screen?
Yeah.
Okay, so so I was given a study to present. The study's title was Expect Comment on Pulmonary Metastectomy. And it was basically a study that was done by multidisciplinary team. There were like a lot of people involved, physicians involved from thoracic surgery and public health services and oncologists. I did look into the supplementary data. I didn't find that how many number of physicians were involved, but it was that it was a multidisciplinary team. So introduction, that why did we needed this study, or why was this study needed? Oh, there were 3 points that they came up with, which was that they needed a standardization of literature to see that how pulmonary metastectomy or PM, there is lack of evidence in the literature. Second, they wanted to find out that how many challenges how challenges were faced in PM literature, and they wanted to highlight the shortcoming that was present in PM literature, such as the absence of the randomized control trials and the use of historical controls. So the methodology that they used in the study was expert consensus methodology. So what is this methodology? So basically what they did was they did collected a task force that was mainly included physicians, and then they did literature search, and then they used the modified Delphi method, which is when they ask at the end of every section from the physicians or the multidisciplinary teams if they strongly agreed or not agreed or relevant. So what they used was they used studies from 1990s, 1990. And then the most of the studies that included mastectomies, pneumonectomies, thoracotomies, and mostly it was based on surgeries. And then the overall concept which they wanted that to find out through these studies was the 3 questions they asked. So the first question was that, is PM associated with the cure? That was there any evidence found that was it associated with cure? And then the second question was, is PM associated with prolonged survivals without cure? And the third question was multidisciplinary care, does it affect the outcomes of the cure or not? So after for to look for these 3 questions, at the end of the whenever they did all their research and everything, the consensus statement, it included two statement, which was like, when caring for patients with cancer and pulmonary oligometastasis, PM should be considered within a MTD and carefully individualized. As you can see, that 92% of the team strongly agreed. And then the other statement was, in oncologically and medically appropriate non-small cell lung carcinoma patient, tissue from the PM should be sent for genomic and molecular analysis, including programmatic death ligand to guide the further therapies. 67% strongly agreed. And then, so these were the main 2 points that they came up with, that why it should be done. And this was the framework. And then in the study they talk about how we will evaluate a patient that we are considering for a PM. So these were the points that they wanted to include. First was the selection and exclusion of the patient for PM. Next was the imagining modalities. Third was the risk assessment. Fourth was the recurrent disease, was it a repeat PM? And then surgical objectives, and then safety, surgical morbidity, and mortality. As you can see in this image that was included in the study, that this is the timeline, or this is the steps that we would follow to consider a patient for the PM. Next was the technical aspects of surgical PM. So what were they considering whenever they were considering the surgery for the PM? So these were the three main points that the physicians agreed on that should be considered, and they were extent of resection, how smaller or how big was the metastectomy, and then surgical approach, whether that was direct, whether that was systematic, and then lymph node management. And this was the diagram in which they explained all of this. And then after all this, these are the 5 points that the physicians came up with into like how the patient should be selected. So the first was that in oncologically or medically appropriate patients, PM can be considered with a preference for miss owing to the shortened post-operative recovery and lessen effect on short-term quality of life. So it was basically, the first part was about the quality of life. And as you can see, 75% strongly agreed that the PM should be done for better quality of life. Second point was the goal of the RO and pulmonary parenchymal sparing cannot be accomplished by the MS and themselves to open approach like thorectomy, sternectomy, or clamshell open technologies are appropriate. As you can see that 83% strongly agreed that the open approaches were better in surgical approaches. Third point was that pneumonectomy to accomplish PM is discouraged except in carefully selected patients undergoing multidisciplinary management. As you can see, that 62% strongly agreed, while 30% only agreed. So pulmonectomy was not that, not considered that good. Fourth point was candidate selection for PM is best suited to patient harboring 3 or fewer pulmonary metastectomy. As you can see that only 33% strongly agreed, while 40% agreed, and 88% were neutral. So this point shows that the PM should be considered for even fewer metastasis. And then lymph node sampling dissection concomitant with PM should be considered because pulmonary metastasis accomplished by the mediastinal lymph node metastasis predicted poor survival. As you can see that 39% strongly agreed and 38% agreed. So this point was also not very conclusive. Then they talked about cancer type specific management, and the types of the cancer that were discussed were 6 types of cancer. So first they talk about the colorectal carcinoma. So there were a lot of studies done regarding every type of cancer, but I included the ones that were, the results, for which the results were somehow good or better than other results. So there was a data collected from selected patient, and it shows that the 5-year survival rate after PM to increase from 30 to 60%. So this was very good for the colorectal carcinoma. And then the physician statement included, as you can see, that 92% agreed that the PM should be done in a colorectal carcinoma patient with metastectomy. Then the next one was renal cell carcinoma. In renal cell carcinoma, they identified that the renal cell carcinoma was associated with different risk factors, but they identified that age was one of the biggest factor, and metastectomy when done with the younger patient had 70% more chances of survival. And as you can see that 92% of the multidisciplinary team strongly agreed that the metastectomy should be done in a renal cell carcinoma patient. And then this was the table that was included in the study. As you can see that the 5-year survival rate even goes up to 53% and 47%, and then even the 10-year survival rate is, there is evidence that it is good. The next study cancer that was discussed was malignant melanoma. And as you can see that 75% agreed that malignant melanoma patients should go through PM. The next cancer that was discussed was sarcoma.
Can you go back?
Yes, doctor.
So you don't have the 5-year survival data?
No, Dr. Liam, because different studies were done. Some were case series, some were meta-analysis, some were systematic reviews. I just included this one because it showed that 1,000 out of 1,000 patient melanoma, they had improved survival rates as comparatively other visceral cancers. So that's this one I included. I don't think that there was like 5-year survival rate study included in the malignant melanoma one.
Mhm. So why don't you, well, there's gonna be multiple papers. So
Mhm.
even if it's not 5-year survival,
Mhm.
why don't you make per primary site, whatever the metrics is, 3-year survival, median survival, whatever that is, find a comparable matrix that it can be used to make a table for each primary site and improvement before and after applying metastatectomy. Okay.
Yes, so Dr. Chae, we are with Dr. Wu. So we have included most of these cancers, and we are finding Dr. Wu has done with his data extraction for the renal cell carcinoma, and I'm doing sarcoma, and Brendan is doing head and neck, I guess. So I think melanoma is also included that. So once we're done with that study, I think we should be able to come up with the tables because we're also doing an umbrella review.
Okay.
Yeah. So then the sarcoma, as you can see that strongly 8% the sarcoma, 92% of the multidisciplinary team agreed that the PM should be done for a sarcoma patient as well. And then the head and neck.
Go back. So sarcoma is, I think, particularly important. And then the renal and I mean, and so there's something unique about lung that compared to other metastatectomy sites, there seems to be a bigger benefit doing lung metastatectomy. And we have to, and I think sarcoma is the prime example. They just love to go to lung. And just discussing the biology and what is it? What pathway is turned on? What makes it, you know, so not just the outcome, but I think we need to study a little bit more about the biology. What makes it well, I guess sarcoma is unique. I think renal is unique in that regard too. And then you have something like germ cell tumor. It just loves to go to lung. So what is it that makes it the metastasis to be prone to land in lung? And has anyone looked at mutation at the difference in the DNA, RNA, or immune level? Yeah. So I think understanding the biology is the next step, but keep reading about those as well when you do the review. Okay.
Okay. Yeah, doctor, I'm doing sarcomas with Dr. Wu. So in the next meeting, I will come up with the answer that why sarcoma loves lung so much.
Yeah. Okay.
Okay. And the next that was
Oh,
discussed was head and neck cancer.
the other question is, yes, we know there are better outcome, but those who fail to show good outcome, let's say, did pneumonectomy, if you fail, do you fail because of another lung metastasis, or do you fail with non-lung or like distant metastasis? And you can't keep doing metastatectomy because you need air reserve, lung reserve to breathe. That's where we're talking about transplant here for that very reason. But when you look at different organs, I don't know, but if you can find any article that talks about like if they failed, is that what is the reason for that distant mets? Is it outside lung or is it still within lung? So I think that kind of data is also important if you can find one.
Okay.
Okay.
So so the next was discussed head and neck cancer. As you can see that the 20 retrospective reports over the past 20 years were reviewed, and only 2 reports showed the retrospective compared with chemotherapy. So there was not a lot of evidence. So you can see that only 42% agreed and 42% strongly agreed, and then 40% agrees with the 12-month survival rates. So for the head and neck cancer, it was not as good as comparatively the other cancers. And
Go
then
back,
you
go
can
back, go
see
back.
that.
So, but they still agree. That's really interesting. But
But
these papers show there's, oh, so this is okay. Show me.
this is the table that was given. So as you can see that even the 3-year survival rates are like good, but not that good like the other, like sarcoma or anything. And then the 5-year survival rates are very low.
Okay.
And then the next one they talked about was non-seminatus germ cell tumors, and what they agreed upon 67% of the multidisciplinary, that a PN and a platinum-based chemotherapy should be, would increase the chances of survival, and 67% of them strongly agreed.
So we'll go back. So it says do it after chemo,
Platinum-based chemotherapy.
and then do it after normalized level. Okay, so 62, well, that's ranging from strong bias, or is this basis? Where is this bias? I don't know.
Based.
Okay.
Yes, it's.
Okay, yeah, go ahead.
And then the last cancer they talked about was breast cancer, and it was really good. And they did a meta-analysis of 16 studies which evaluated around 2,000 patients, and that showed that the 5-year survival increased to 46%. As you can see, that 58% of the multidisciplinary team strongly agreed that the PM should be done in the breast cancer patients. So for breast cancer, it was really good. For colorectal, it was really good. For renal carcinoma and sarcoma, it was really good. Whereas they didn't found any strong evidence for head and neck cancers. So this was it. And in the conclusion, they said that the management for PM still remains uncertain, and a multidisciplinary team, which includes oncologists, physicians, and thoracic surgeons, to go beyond their limits and come up with better solutions, because it still remains uncertain even after doing so much studies. Thank you, and I hope you see the Northwesterns in my presentation.
Thank you. So
Thank you.
yeah, no, I was laughing because the the conclusion is like just don't do it because it can be done. It's so funny. Anyway, yeah, the data looks better than I thought. Anyway, Dr. Wu, any comments?
Yeah, so I think there are many unanswered questions because this expert consensus has actually no numerical background or some, data. So as they mentioned, there's no RCTs and there's also no, I think, prospective studies done. So they are depending on the result from meta-analysis and others. So our approach is to generally overview all types of pulmonary metastasis from all types of cancers. As you mentioned, after surgery, there are many patients who have metastasis, but in many reports, there is no information about that actually. So it will be limited, but we will try and we will anyway try to show any relevant questions. So I will just briefly present about the whole design of this study and the process we have done and we need to do.
Mm.
So actually, there are many meta-analysis, about 50 cases of papers already published in this topic.
Mm.
So our topic will be like this. We will review pulmonary metastatectomy low for secondary lung cancer. I'm not sure secondary lung cancer is an appropriate term or it should be better another term. Maybe you can recommend. So
I don't think we use secondary lung cancer much. So it will be pulmonary metastatectomy for
primary lung cancer.
secondary.
Last stage cancer or stage 4 cancer? Because that's the term we used when we were doing the literature.
Yeah, but it should not include in lung cancer, non-small
Yeah.
cell lung cancer.
For I would say non-lung cancer.
Okay,
Non
we will.
non-lung primary cancer.
Okay.
Non-lung primary cancer.
Okay.
Wait, doesn't the term pulmonary metastatectomy itself, like, like from that term, you can imply that there's like a primary tumor outside of the
yeah.
lung and it has metastasized to the lung. Sorry, I can't pronounce it.
Yeah, that makes sense. But to make it clear, so I think we need to put some other things. I think so.
Yeah, you can say there is a contralateral lung metastasis for even for lung primary cancer. You use that term. That's why bilateral lung cancers are metastatic cancers. So you can, yeah, just I mean the role of
Maybe we could just say for lung metastasis.
for non-lung cancer.
Okay, I think we can think about it later, but yeah.
Yeah.
So I searched about 3 search engines. So my term was pulmonary surgery, pulmonary metastatectomy, and meta-analysis. And then finally, about 52 cases of meta-analysis are included in this study. I will fill the reason for exclusion later. So there are many cell types. We were based on many cell types as you saw in the last presentation. And here for me, last week I summarized all results from renal cell carcinoma so that you can understand how things were going on. So this is one chapter of this topic. So finally, these 18 each study is from retrospective studies, and it all included 1,600 patients. So, and I all meta-analyzed the patient characteristics. So patient age, sex, and solitary or multiple, unilateral or bilateral. So as you can see about in analysis, renal cell carcinoma, about 29% patients has surgery for bilateral lung lesions. And the pneumonectomy is about 6%, so it's not that high. And then, as you can see, wedge and segmentectomy accounts most of the surgery. I think the important information in many articles were about the complete resection. So they many compare the result between complete and incomplete resections. So 88% was complete resection, and this is 1 year survival. So this is how I did meta-analyze the survival rate. This is kind of proportion meta-analysis. And as you can see, the data is quite a little bit heterogeneous, and this is 2 years. This is for 3 years. This is 5 years. If you see the forest plot, the data is very heterogeneous. So it means, it is kind of limitations, and then we will find how to make it more homogeneous. And this is a 10-year survival rate. And in summary, the 1 year, 2 years, 3 year, 5 year, 10-year survival rate and lower upper 95% confidence interval is like this. So we will make this kind of graph for each cell type. and we will compare their 95% confidence interval between all cell types. And if there's any difference, it will give some idea for the clinician that, yeah, renal is better than colorectal, or renal is similar to colorectal. So we don't need to worry about cell type, something like that. That is our goal. So from our study, anyone who are interested in metastatectomy, they can see their results and compare what will be better. And also we will find out how to make this figure more, easily identifiable.
So yeah, I know you got overall survival. Did you find disease-free survival?
Yeah, let me show you. So actually, many studies did not report. This is the how I found out the information in each studies. So for reasons, many studies didn't mention synchronous, metachronous, solitary, multiple, unilateral, bilateral. Also, disease-free interval is kind of from after treatment for primary cancer when when the pulmonary metastasis happen. So there is some data, but not all. And for systematic treatment before surgery, the data is not that much. Only quite several cases has some data, but they all have information of surgery and complete resection. For adjuvant treatment, there is also not much report, only 2 to 3. And you can see this is overall survival. They have Kaplan-Meier curves and data, so we can add that. But for disease-free survival, as you can see, among 18 studies, about 1, 2, 3 studies only reported disease-free survival, recurrence-free survival. So I think it is because the recurrence rate is quite high. And in this study about 112 among 122 patients had a recurrence, and this is thoracic only and extrathoracic recurrence, and you can see extrathoracic recurrence is quite high. Yeah, and other studies they didn't mention about recurrence. I think this is because of some poor result, or I don't know. So it will be, and we can maybe discuss in our studies about how we can mention about recurrence.
But still, you
And-
have what the 2 studies mention it, or 3?
Yeah, 3, 2. So we can make forest
Yeah, we can
plot
still
and
do pulling for these.
yeah.
People want to know.
Yeah. So we will gather all this one. And
Yeah.
interestingly, many studies mention compare the Kaplan-Meier curves based on algero or incomplete section. So I think later, after we sum up all cell types, and we will divide the result according to complete and incomplete.
Yeah.
If complete is much higher, then it can be very good, some kind of evidence to say,
Yeah.
pneumonectomy, bilateral pneumonectomy will be good. So that is our thinking.
Yeah. So pulling by R0 or not, and showing the difference would be really good.
Yeah.
By histology. I think that's really good.
Yeah.
And if non-R0, it's just like ovarian cancer debulking. Just debulk.
Oh, yeah.
Yeah, it's gonna come right back because you left something behind. Yeah,
So
I like the plan. I like the plan.
yeah, so this is the process we have done. So I submitted the study protocol to Prospero for later publication. And systematic search is almost finished, and data extraction is going on. And colorectal there are so many papers, and I will do that. But I think the more important part will be head and neck and sarcoma, because these are so many very curious. Because RCC colorectal, many agree, but head and neck sarcoma, many will be very curious our
Yeah.
data.
And
then
we did one in adrenal cortical, and we're gonna actually do second case now.
Yeah, there are about 2 meta-analysis about adrenocortical. So we will add them also and other types. So about 10 cell types will be included. So yeah, that is our goal. And then as soon as we finish each section data extraction, we will do meta-analysis as I showed here, and then we will make abstract. And for the later, for publication, we will start quality evaluation for each meta-analysis. This is not taking much time. So then we will finalize the process. And these are the many questions that we need to answer, I think. But my concern for this study is what should be the control group for comparison? So, we will present data about 5-year, 10-year, 2-year survival rate of metastasectomy. Then, we can compare within this group by, R0 or annual resection. But other than that, what should be a kind of control? So, if 5-year survival is around 50, then it means it is still valuable, or it should be more than 70. I don't know. So if you have any idea for the best some group to compare with our patient group, it will be necessary to show the superior or good outcome of surgery.
Yeah, I think so you can't randomize, so you're never gonna have a control group.
Yeah,
And
sure.
it's always going to be selection bias. Patient has to be fit enough to go into surgery. If you have, everything else hard and everything else to be good enough to undergo surgery. So you're kind of selecting for good performance on top of the oligometastatic disease. And you can't get a control where oligometastatic disease were treated with chemo only. So you're just left with the general statistics from CDC or Sears data where you have just this is like historical most recent stage 4 colorectal data. Some of them, and then you can't even select who actually didn't get pneumonectomy in those cases. So this is just like a general stage 4 survival rate, and this is how far you can do. And the other one is, now there's so many data on SBRT, but SBRT is more, you don't know R0, it's limited, so their performance is not, it's not going to be a good question, but they can be a surrogate because we don't give SBRT unless they are oligometastatic. So there are actually prospective studies done on SBRT where it's not palliative, meaning like, oh, there's hemoptysis, let's give radiation. There's like, bone pain, let's give bone radiation. Those are all palliative, but when patient is asymptomatic and their targeted therapy or immunotherapy is going well, but for the consolidation purpose, they give SBRT just to make them live longer with 0 symptom. So in that case, it's the most comparable oligometastatic, and they're selected who's going to tolerate SBRT, and they're asymptomatic. So I think for lung, there's a lot of SBRT papers. And then now that became a standard of care for oncology practice. It wasn't like 5 years ago. MD Anderson group published a lot. So maybe if you have like a survival rate from those papers, that could be a good comparison. And then I'm sure they have categorized them by the primary cancers. So yeah, look for those papers. So I think you should do 2 just general stage 4 comparison. And I don't know, you'll find like lung metastasis only. That's gonna be a challenge. But if you can't find it, then you just have, general stage 4 would be this for this cancer. But then oligometastatic lung treated with SBRT, those papers you will find. So maybe but so what I was telling you is it has significantly improved overall survival by doing SBRT as often as you can. And that's what I do in my practice. I use SBRT a lot. And it used to be that, this is a systemic. I think that's a lot of it is because, so the notion is very different than metastectomy because SBRT, let's say I have 5 lung lesions. I give chemo, only 1 grew and all the others shrink. And I still have 4 other lesions, but I SBRT the one that grew. And it just stays stable for a very long time. So the notion's in that case, little different than pneumonic, because you wouldn't do pneumonic wedge resection for that lesion. And then leave the 4 behind. So that's little different, but you can imagine that the prognosis would be a little worse than metastatectomy, but still it's something you can still compare and get some meaning out of it. So I would look for that. Yeah. Okay, good question.
Is it too far to compare the survival with double lung transplant from non-lung cancer?
Double lung transplant for non-lung cancer? Oh, non-lung cancer.
Yeah,
But these are stage 4 lung cancer patients.
I mean, finally we want to go to, apply lung transplant for extensive metastasis.
Yeah.
Then maybe we need to show and compare the, generally lung transplant outcome for 5 year, and it should be similar. Then maybe can do. But if survival lung cancer, lung transplant too low, then metastasectomy, then I'm not sure. But this is too. I think too. I went too far, but
Yeah, because you're comparing lung cancer, or the stage 4 cancer to like COPD patients, you know what I mean? Like not.
Yeah.
Yeah. I think within so UNOS has still BAC. Well, BAC is a little different, but still it's
Yeah.
cancer. So yeah, maybe UNOS lung cancer data, maybe you can compare. Yeah, I still think it has to be cancer to cancer still.
Okay.
Yeah. Okay, so yeah. Keep us updated as you get more data, tumor type by tumor type. I think the more I think about it, this is a really nice project. Um, I think with the advent of immunotherapy, because these data are coming from non-immunotherapy era, like 5 year
I think so.
survival. Yeah, because with immunotherapy, if you have less tumor burden, the immunotherapy works better. That's why neoadjuvant is working so much better than metastatic setting in both in melanoma and lung cancer. So imagine if we lower the tumor burden by doing metastatectomy and then do adjuvant or consolidation immunotherapy in these tumors. I think the outcome, the survival outcome will be even much better.
For that topic, maybe it is better to do retrospective for showing short-term results.
Short term, like what?
I mean, I don't know how long the immunotherapy has been implemented here. So if there is 3 or 4 year survival, then maybe as a retrospective study, you can do that.
Yeah, so the melanoma got first approval 10 years ago.
Yeah.
And then slowly lung cancer and renal got approval like a couple years later. So I mean, if these data are with like a 10-year period, it's okay, I think.
Okay.
Yeah. Okay. So good. Okay. Anything else, Dr. Wu? Did you talked to Dr. Tarek? Not yet?
Yeah, not yet.
Yeah. So Liam, make sure Dr. Wu meets Tarek and they can sit down and go over the Tarek's data. And then Dr. Wu, you can help Tarek write up the whole case series about our dream patient. So he's writing the case series. So you can
Okay.
definitely work with him about the metrics and how do you report the outcome and all that. And then Terry can work with you, like he can talk about the patient's the biomarkers, DNA,
Okay.
RNA, all that. So Liam, is it 6 patient total, including total pneumonectomy, or was it 6 patient?
It should be 7.
7? Okay.
Yes.
7 including 1 pneumonectomy. Okay, 7. So yeah, I told Tarek to do 2 separate paper for that, and then recent cancer history paper, and then just like a case series for adrenocortical because it's the first of its kind. Right, Dr. Wu, you haven't heard any adrenocortical double lung transplant.
Yeah, I think so.
Probably it's the first one in the world.
Yeah.
Yeah.
And I know, is there any difference from perioperative management for those patients? Because many people are interested in that, you know.
Like how? Like what do
I
you?
mean, you know, if, you know, when we are expanding indication for lung transplant. So, you know, this is just kind of issue of selecting patient, then,
Yeah.
you know, process is all same. But if you have some specific protocols or monitoring or some criteria, that will be very interesting topic for the, you know, whenever we do those procedures.
Yeah. So we don't, as far as patient care, there's nothing different. As far as biomarker tracking, for all our dream patient, including the adrenocortical, what we're doing is, and work with Tarek to describe and make graphs and figures. So what we're doing is ctDNA. We do 3 different types. Garden 360 measures all the mutations. Garden Reveal measured methylation level. And then Signatera measures, I think it's 16 base gene PCR based on the tissue. So 2 Garden assays are just measuring any ctDNA, versus Signatera is the only one that's tissue informed. So we do 3 different types of ctDNA, and then we do cell search, circulating tumor cell, and then we do baseline just proteomics, OncoHost and VeriStrat. That's the mass spec and ELISA based proteomics assay. But and then we track the ctDNA every 3 months. So that's something that's unique. And we check the pre-transplant, after transplant. So yeah, that's a lot of data. So okay. So that paper needs to come out very soon. So yeah. So Liam, please have 2 of them meet up and yeah. So Tarek is what used to be a medical oncology attending professor in Turkey, but he's doing extra like a 2-year fellowship here with us in phase 1 clinic. But his plan is after that after 2 years, that he will stay here as a faculty, like Dr. Pedro did the same thing from Brazil. Yeah. Okay, good. Anything else? It's good. Okay. All right, very good. Okay. Sally, can you show us your updates?
So, we're still in process of working with Imagine AI, and we're gonna have our meeting tomorrow. And we're gonna discuss about the results that came out. I checked again yesterday to make sure that I didn't make any mistakes, and I didn't. So I was able to cross check, and yeah, so the data that we got is what we have. So we'll have to discuss that with Imagine AI team tomorrow.
Okay.
And then I do have a presentation. Oh, and then Evan Pearl got back regarding Imagine AI, but he just asked for more information. So Dr. Leon sent them more information, but we didn't get anything back after that, right? Just to make sure. Dr. Leon. Okay.
No.
Even biodistrict,
Nope.
nothing. Okay. Yeah, we'll just keep bugging them. Email them every week. But yes, and then yeah, so I can just share my presentation. I will be presenting on, let me send the link first. Oh, no. Wait 1 second. All right. So I will be presenting on the AI-powered assessment of, oh, okay, there you go. Can you guys see it?
Yeah.
Okay. Yeah, pathologic response to new adjuvant atezo in patients with non-small cell lung cancer results from the LCMC3 study. So it's a very recent study that came out this year. So yeah, it's just like a background introduction. It's a pathologic response is a clinical measure of histologic changes associated with neoadjuvant treatment, usually assessed by identifying areas of viable tumor with distinct fibrotic and necrotic tumor beds. So the established categorical pathologic response measurements are PCR and NPR, and PCR is the absence of viable tumor on histologic evaluation of primary tumor specimen. And NPR is defined as less than or equal to 10% viable tumor cells in the identifiable resected tumor bed. So both PCR and NPR may be predictive for DFS or event-free survival in clinical trials and may eventually be validated as regulatory endpoints. Emerging data from neoadjuvant anti-PD-L1 and PD-1 trials may provide growing support for pathologic response as valuable efficacy measure in non-small cell lung cancer, and the use of PCR and NPR in clinical trials and routine clinical practice to assess response to neoadjuvant therapy for early non-small cell lung cancer requires efficient integration into clinical trial operations and standardization. So scaling these approaches could be challenging as manual assessment is tedious and it's very time consuming. So automated machine learning based approaches could enable scalable, standardized quantification of tumor bed and residual viable tumor areas. So in this study, the phase II Lung Cancer Mutation Consortium 3 study. They evaluated preoperative atezo in patient with resectable non-small cell lung cancer. So according to the paper, this is the first report of its kind, and the authors, they used the clinical trial data from LCMC3 to determine inter-reader variability among local and central pathologists. And they also developed a CNN-based model that digitally assessed percent viable tumors in whole slide images and determined NPR according to the IASLC recommendations. So the CNN-based model was also trained to distinguish and quantify tissue components such as like tumor bed, viable tumor tissue, necrosis, and tumor-associated stroma, etc. So here are the methods. So first, they looked at prevalence matched NPR cutoff for digitally assessed percent viable tumor. So the proportion of patients with visually assessed NPR yes was determined using the less than or equal to 10% viable tumor cutoff to match the data. And a digital cutoff was then defined by determining the closest cutoff that would result in an equivalent proportion of NPR yes and NPR no cases with digitally assessed percent viable tumor. And by using the digital cutoff, agreement between visual and digital NPR was evaluated using Cohen-Kappa. And as we know, Cohen-Kappa compares the probability of agreement to the expected. So that's the method. And the next method that they used was machine learning model development for prediction of viable tumor. So slides from LCMC3 samples, once again, were scanned at 20 magnification using their scanner, and 3 separate deep CNNs were developed and applied for pixel-wise classification for tissue type in each H&E stains, whole slide images to calculate the percent viable tumor using digital pathology. So first they used artifact model was applied at 1 millimeters pixel, etc. You can read the slides. And so the tumor percent viable tumor is defined as the sum of tumor epithelial area on all slides for a case divided by the sum of the tumor bed area on all slides for the case. So for model development, so basically 1984 slides from proprietary and commercial H&E stained non-small cell lung cancer samples were included in the training set, and there were 72,000 annotations by board certified pathologists were collected, and those annotations were checked then by quality by board certified path AI pathologists. So it was very and also like annotations of poor quality because of inaccuracies were discarded from model training. So they had like training stage and then validation set and then testing stage. So as you can tell, it was very, they really checked repetitively for quality purposes. Yes, and then this is just the representative test set slide with the artifact tumor bed and tissue overall. And then for final model performance, it was qualitatively reviewed by Path AI and Genetech research pathologists and the LCMC3 Central Pathology Committee. And on the other hand, the quantitative performance of the tissue model was measured by comparing model predictions of viable tumor tissue necrosis and tumor-associated stroma against pathologist annotations on the test set and calculating precision and sensitivity compared with pathology assessment. So to do that, F1 score was measured by this equation down here. So basically, high F1 score demonstrates that model's detection exhibited like high precision and sensitivity compared with assessment by the Path AI network of pathologists. And then the result now. So first, when the inter-reader agreement was assessed by computing pairwise Pearson correlation of percent viable tumor among the 4 visual reviewers, the correlation coefficient was 0.87, which indicates high degree of agreement between the model and pathologist in quantifying the tumor bed in non-small cell lung cancer. And the agreement for visual NPR among all 4 pathologists was 92.1%. And initially, there was disagreement on the NPR determination by at least one of the 4 reviewers for 12 patients. So if you look at C here, after the central reviewers reviewed the discordant cases and reached a consensus, 7 cases were discordant by local pathologists. In all discordant cases, the local pathologists tended to underestimate the percent viable tumor compared to the central reviewers. And then there were 11 patients who were assessed as PCR by at least one central reviewer, and the agreement for PCR among all 4 pathologists was 98%. And next, for deep learning models for pathologic assessment. So deep learning model was developed to automate scoring on digitized H&E stained histologic slides. The model used 3 separate deep CNNs for pixel-wise classification of artifact tissue and tumor bed. So model predicted viable tumor tissue, necrosis, and tumor-associated stroma were compared with pathologist annotations. So here, once again, like F1 scores were measured. And as you can see, these are the results of F1 scores. Tumor bed was 0.79, non-tumor bed was 0.91. You can see, so the detection of tumor-associated stroma exhibited high sensitivity. Let's see. However, the area predicted to be tumor-associated stroma was not included in the calculation of pathologic response and therefore did not affect digital pathologic response assessment. And then deep learning models for pathologic assessment, once again, just adding on comprehensive, so additional validation of tumor bed model used comprehensive manual pathologist annotations of tumor bed versus non-tumor bed regions across the entire whole slide images for like 150 slides. And Pearson correlation coefficient between tumor bed areas predicted by the model and annotated by board certified pathologists were around 0.94 for the training and validation slides, and it was 0.92 for test slides. And this result suggests a high degree of agreement between the model and pathologist in quantifying the tumor bed in non-small cell lung cancer. And the intersection over union values of the areas deemed to be tumor beds by the model versus the pathologist were very highly acceptable with 0.82. And yes, the next. So they also looked at correlation between digital and visual percent viable tumor. So they looked up the slides with H&E stained surgical tissue samples from 136 patients were digitized. And the primary endpoint in LCMC3 was NPR derived from a visually determined percent viable tumor assessed by local pathologists, and it was strongly correlated with the results obtained through digital assessment. And the slope of regression, if you look at this graph, was 0.28, and this indicates that digitally determined absolute percent viable tumor was systematically lower than the visual assessed value for a given sample. So this discrepancy can be explained by like differences in how pathologists and algorithm estimate viable tumor. So tumor associated stroma, once again, specifically excluded from the digital calculation, may be graded as viable tumor in visual assessment. So there was that discrepancy. And then next is digital prediction of visual NPR. So digitally assessed NPR predicted visually assessed NPR with outstanding discrimination with AUROC of 0.98, and which is amazing. And when adjusted for the systemic differences between visually and digitally assessed percent viable tumor, the proportion of the NPR yes at a 10% cutoff that we talked about before was 20.6%. And by categorizing the lowest 20.6% of visually assessed percent viable tumor score as NPR yes, the resulting digital NPR cutoff was 5.5, which resulted in 93% agreement for NPR assessment. And this is the figure, and I'll just briefly talk about C and D. So C basically shows that like digital NPR was discrepant with local visual assessment in 5. It's just saying that 5 digital NPR yes cases and 5 digital NPR no cases. And then for figures 3D, the digital NPR no cases had percent viable tumor values similar to the visual assessed values. And as these cases were close to the threshold, they were more sensitive to the small variation in the NPR cutoff. And then I think this is the last results slide. But basically, they looked at the association of NPR with long-term outcomes. So locally assessed NPR was used as a reference standard when comparing with digitally assessed NPR. And these points goes along with ABCD in figure 4. So first graph, it shows non-significant trend towards longer DFS in patient with visually assessed NPR yes versus NPR no. And then B, on the other hand, shows significant trend with digitally assessed. And then C is non-significant trend towards longer OS in patients with visually assessed. And then D is significant trend toward longer OS with digitally assessed. And then 2-year OS rate was 93% versus 84 for visually assessed, and then 96 versus 83 for digitally assessed. And then lastly, NPR yes cases for both digital and visual demonstrated a trend towards the best long-term outcomes. So these are some discussion points that the paper talked about. So some advantages of AI-powered assessment of pathologic response. First, it could assist pathologists in improving the diagnostic accuracy and standardization of diagnostic interpretation. And they did mention how it shouldn't be standalone tool yet, but it should assist pathologists for sure. And then second, a single case can be achieved in minutes, compared 30 minutes to 60 minutes for visual assessment. So very time-consuming tasks that can be done very quickly. And then 3, images can be transmitted electronically for evaluation instead of actual requiring physical transportation of glass slides. That's something that we're trying to do with all the companies right now, like try to scan everything and send it out. So it's very, once again, time consuming it saves time and It's good for sharing data, transparency in data. And then 4, overall cost of implementations can be reduced.
Yeah.
And yes.
Oh yeah,
Sure.
go ahead. You had more slides.
Oh, this is the last one. So just future direction in light of potential for misclassification by the model, supervision and review of the model by a pathologist would be recommended. And these methods have yet to use prospectively in large-scale clinical trials and may potentially simplify clinical trial operation and accelerate trial readout. And eventually, as targeted neoadjuvant therapies become adopted in clinical practice, digital assessment of pathologic response is likely to become an important day-to-day tool. Yes.
Yeah.
Thank you.
Good. Nice review. So the purpose of Journal Club for this paper is that because we're now getting into AI imaging space, pathomics and radiomics both included. I think pathomics, as you can see in this paper, really accurate, and it did correlate very well with clinical response. So Sally, please share this with Alan Cho, because this paper needs to be in his review as well. And really, I think the result can't be better than this. Like non-significant to significant when you actually do it from visual to digital. And right now a lot of Indian radiologists are reading US hospital CT scans. Now I think a lot of Indian pathologists are going to read H&E slides. The time will come very soon. And the money we pay to radiologists, pathologists per time is a lot. And I think people are going to go to more cost friendly places, and it will still be a pathologist, radiologist involved, but I think the more in the future it will all H&E slide, PDL, well, whatever it is, it's all will be automatized, or whatever it is, it will be all streamlined digital process. I think the radiomics will be the same way. It's coming. We're just tasting the future. It's going to be that way. And I think using that technology, and our job is really combine that with the clinical factors, the genomic factors or radiomics factors, and show that we can do better with multimodality prediction model. And really, to us as an oncologist, how do you tailor treatment based on this? And this is telling us response to immunotherapy, looking at the post-treatment H&E slide. But we also want to see whether pre-treatment slide can predict response. But then we're going to have the response anyway from the neoadjuvant post-resection slides. So we'll use that to predict survival. And for oncologists like myself, the question is, do we need to do more consolidation therapy or not? Do you want to give 1 year of atezo or not? So that's the burning question that we have. So I think we'll need to look at that as well. But anyway, we know what to do with let's say Picture Health, Lunit. This is exactly what we need to do. Compare digital versus visual, and compare that with DFS OS and see if there's any improvement in prediction. Go from there. So this serves as a nice paper. This is exactly what we wanted to do, but I kind of got surprised that their sample size is like a couple thousand each set. And this is Genentech has a lot of money. Path AI is a direct competitor of Lunit. So I congratulate them on the very first seminal paper out there showing the utility of the digital H&E slide CNN modeling. Yeah, so very timely article. Thanks, Sally. Okay. Before we go to Haesung, let's take a 10-minute break. Okay. Okay, I am back. Okay, Haesung, you can give us update.
Yeah, before I forget, I wanted to mention the double lung transplant, receiving the double lung transplant for cancer's purposes, like patients with cancer receiving DLT. That was a question, right?
Yeah.
Yeah, I used the current database, the September 2023 database, to find those patients, and I couldn't find any. Like, no one received DLT for cancer. And this is after excluding a bunch of patients, because if we're interested in finding out whether these patients developed cancer after receiving DLT, then I will have to exclude many of them because many of them don't have that data. Like, before excluding this data, then we might have some patients who received DLT for cancer, but after excluding, we don't have any. Does
So
that make sense?
I don't understand. So if you remember Andrew Yang's presentation, there's a graph about data with lung cancer indication, their survival rate. I don't know how that graph was made.
I mean, so Jisung gave Dr. Jian the raw data, but at that time he didn't do a lot of exclusion. Like, he included some patients who had pre-transplant. I guess pre-transplant malignancy. Okay, yeah. So he didn't filter out many things, but here, let me just do another thing. I'll get back to you on this. Actually, there's another thing I should do. I excluded all the pre-transplant malignancy. So yeah, sorry. Let me just do this over again. Give it to you. But anyways, what I'm saying is, like, Ji-sang and I have different exclusion criteria, and like mine was a lot stricter.
Oh, okay.
But yeah, I'll try to redo this actually.
Okay. Yeah, Dr. Wu, when you come in, just work with Haesung to make sure you also agree with all the eligibility criteria to do that analysis.
Okay.
Okay, yeah. Okay, Haesung, you can move on.
Yeah, so I'll start with DART again. The non-epithelial ovarian cancer, and you'll see we're still waiting from JNCI. It's been sent to external review and we still haven't heard back.
Okay.
And then for BAC, that's been submitted to
Can you
JIT.
show me the Google Doc that you made for the
Oh, yeah.
so we can look at it and
For BAC, that's been submitted to JITC, but they said they suggested removing the age and sex columns from the supplemental table. And so would you still be okay with removing these columns and resubmitting? I think Liam, I don't think you resubmitted, right? After we talked yesterday.
I did after removing age and sex, but we can withdraw if we have to.
what do you mean withdraw?
Oh, so basically, we submitted this, and apparently having the age and sex column is against their like privacy. They like considered patient identifiers for the JITC, so they wanted us to remove it. So Haesung, and so our question basically is, are you okay to remove age and sex columns for our submission to JITC?
Yeah, just for the JITC. I think it's fine for other papers, but I'm surprised that they make big fuss out of it. Yeah.
Yeah. Okay. Yeah. So we'll just proceed with JITC submission, having removed the age and sex columns.
Okay, because the first time you only removed the age column, but you're saying you removed both and resubmitted?
Yes.
Because I didn't receive an email after that. It was just after the age column deletion.
So sent them an email with the updated draft.
Instead of
and then-
emailing, you should just resubmit, like just change the manuscripts file.
I couldn't. Like I
Oh.
needed to, they needed to like give us access to do it. So that's what I'm waiting for.
Oh, okay. I see. Okay, well, that's that. And then thyroid, I contacted Kara yesterday and she still hasn't given us any update about the
Okay.
future analysis. So we'll have to wait for that because I just contacted her yesterday.
Okay.
And then for clear cell gyne, I sent you the final draft. I wonder if you forwarded to Dr. Kurzrock and the rest of the team. Or for the rest of the team, I'll have to do that after Dr. Kurzrock gives us approval.
Oh, okay. So you send me the final. Okay.
Oh, you replied. You said the cover letter looks good, but for the paper and figures, let's go through them during the lab meeting. Okay, so let me show you. Yeah, so this is the paper. What I updated mainly well, there were small edits over for the manuscript, but I think those were okay. It was mainly from Dr. Kurzrock and Megan. Nothing big. It was just more about like how to organize, how to explain the PFS and everything. So I think that should be okay unless you want to go over them, print it out in detail later. What I mainly did was updating the figures, like adding the combined cohorts and then
okay.
displaying each individual cohorts this way.
Okay.
So that's the
The
waterfall
update.
plot.
Okay.
And then the below is the swimmers plot. Same thing. All cohorts resist, I resist, and the rest of each cohort.
Cervical and clear, and rest of it is ovarian. Okay. Okay.
And then the survival, same thing, combined cohorts, and then the rest.
Okay. Okay. Yeah, if that's the only change, then I think we should be fine.
Okay, you can send it to Dr. Kurzrock, and once she gives us final approval, then I will let Patricia know so that we can distribute it to all authors and collect COIs.
So clear cell. Trying to find that paper.
I sent it in January 12th. You can just type in dark clear cell gyne. I can send it to you again too.
So the one you sent to Megan shows up.
Here, let me send it again.
Yeah, can you send me the final one? I can't find it.
Your YJ, right?
Yeah, that at nm.org. This is why.
Okay, yeah, I sent it to you. And then for Desmoid, it's ready for final review, but the one I sent you still had the age and sex columns in the supplemental table. And since we're gonna submit Desmoid to JITC, I'm gonna remove the age and sex columns and send it to you again. But these two are ready for final review.
Okay, so you're gonna remove H6 and then send that desmoid to are you? But it's still Kurdrak has to give final approval for both, right?
Dr. Kurzrock is okay with desmoid.
Oh, okay.
She said I think that was the tone of her voice, like, or her email. Like, she said everything looks fine, just fix whatever like minor things I suggested and we're ready to go.
I see.
So I guess after removing Agent X, then I can send it to Patricia, or do you feel comfortable with sending to Dr. Kurzrock and getting like the final ultimate?
Yeah, I don't know why it takes. Oh, now I got it. So you got this is the final cover letter and the final draft. Okay, now I'm fine. Okay, desmoid. Did you say you send it to me or you will be sending?
No, I sent it to you, but that version still has the Agent X columns, so I will have to remove that.
Oh, okay.
And Dr. Kurzrock seems okay with this, so I think I can just proceed and send it to Patricia so
Yeah,
that she can
send
distribute
to
it to her.
Patricia, CC, Kurdrak, myself, Megan. When you send it to Patricia. For clear cell, do you think Dr. Kurdrak needs to approve it still? She gave you comments, you just fixed it, right? I mean, I guess
Yeah.
I think you should be fine. So do the
Okay.
same thing, just send it to Patricia. This is the final version. Send to Patricia, CC me, Megan, and yeah. I think you're fine. That these
Okay.
are, yeah, just the adding graphs. Okay.
Yeah, and then I'll finalize vulvar and small cell ovarian sarcomatoid. I started working on the manuscripts.
Okay.
Yeah,
Good.
that's
We're getting
the step
there.
forward.
We still
Yeah.
have time, so yeah. Okay.
That's a sort of. Oh, for sarcomatoid, one thing I wanted to ask was this terminology. I searched for many papers and it seems like pulmonary sarcomatoid carcinoma is like a more prevalent term, but in the protocol it says sarcomatoid carcinoma of lung. So do you want to keep it this way, or would you be comfortable with switching to pulmonary PSC as the abbreviation?
So what is WHO terminology then?
Oh. Oh, I guess. Oh, this is sarcomatoid carcinomas here.
Yeah, I think oblong is fine. That's how we wrote in the protocol, so we'll just use that.
Okay.
Good question.
I'll jump into mucinous lipidic projects.
Yeah,
So this is the Tempest Discover project. Starting with the title, if you have any suggestions.
well, I see. What do you mean the title?
Oh, do you not see? Oh, sorry. Oh, let me share this. Okay, now I think you should be able.
So what is your question?
Well, because this is the abstract I'm gonna submit to ASCO. I'm asking if you
Oh.
have any feedback.
Clinical pathological molecular landscape of non-invasive.
I shortened it because of
Yeah.
like character limitation.
I see.
It's very tight.
Mm. Looks good. Let's show me the results.
Well, one thing I need to confirm with the Tempest team is whether this is like specifically invasive mucinous, because there's also minimally invasive mucinous at lung adenocarcinoma. Do you think that's a big deal?
No, I think it's fine.
Okay. So should we just keep it this way instead of asking?
Yeah, I'll keep it this way. It's
Oh, and just by the way, I decided to include this table. I shortened it. I like very like truncated the table because I wanted to show this like, different immune cell type infiltration. I thought
I
it was
like,
important.
yeah, I like it. Older, less likely to be smoked. So for the results, I don't- I understand there's space limitation, but it's always good to show numbers. Older, more smokers, more stage 4. What number versus one number, not just the p-value, but actual percentage difference.
So currently it's like 2,534 characters or something like that, and the limit is 2,600. So
this is max?
if we decide, huh?
This is max.
For now, unless we take something out. I'm thinking of like taking this one out. I'm not sure what they meant by intervals between primary diagnosis and biopsy. Like, is this primary diagnosis like clinical diagnosis based on CT and biopsy is histological diagnosis?
Remember, if you listen to our recording, do you remember? I asked the same thing.
Oh, you did? Oh,
Do you remember?
that's a good question. Yeah.
Yeah, so I don't think it's clinically relevant. You can take it out.
Hmm.
Yeah, rather I would put the number, and for the table, they are counting the numbers inside the table too, right?
Yes.
Yeah. You can cut down on the introduction because that's not our results.
Hmm.
You can cut down on methods too. Like the Wilcoxon, like they were compared, period. We don't have to know what test it was, so you can significantly cut down on methods because people assume that, these tests will be used and they will be described in the poster. It's just, where did data come from? What did you compare, period. Then I think you have room to add the comparison numbers. Let's say older than median age, this versus this, higher percentage than what is, this versus that. So you could do that.
So here for age, it's like median and first quartile and third quartile. But do you want me to write everything and specify that this is median, this is first quartile, stuff like that?
70 versus 68, I
It's
mean,
not significant, yeah. Or
it-
like,
it's not too different, right?
yeah.
But the p-value is low. I would say if we put numbers, then we put numbers. So the answer is yes. So just say median 70 versus 68.
Mm, okay.
And then p-value. Same thing. If stage 4 is different, stage 4, what percentage versus what percentage, and then p-value. So
Okay.
every comparison you make, just put the actual numbers.
Okay. But everything else is okay with you?
Yeah. Good. I
Sounds
think
good.
they read pretty smooth and they're good.
So I'm guessing same thing with lipidic.
Yeah.
I put the cell type again. Okay, so same
Yeah.
thing.
Yeah,
Right.
same thing. Same thing.
Okay.
Yeah, I like it. Looks good.
Sorry, where is oh, stop share.
So if
Okay.
they get accepted for ASCO, that's great. If it gets accepted as a e-poster, which means you don't actually get to present as a like actual poster,
Mhm.
in that case, you can withdraw and submit to World Lung.
Mm.
World Lung, you have better chance of getting it poster, and even there's a chance for oral presentation for these type of large number analysis. ASCO is pretty competitive. So if you get it, ASCO, great, present it. If it's just e-poster with abstract only, then withdraw and submit to World Lung. The World Lung is San Diego. Yeah,
It's always in nice places.
yeah. Haesung, are you going to AACR? Are you-
ACR. Oh. I can't remember what I
AACR is in April.
submitted.
You
Oh,
probably have something. Liam, do you know if Haesung has a poster?
I haven't been keeping track.
I think she might be a co-author on some of the radiomics stuff. I don't think she was first author. Like she, yeah, I don't
I've
think,
been first author for a while.
yeah, because her projects are mainly going to ASCO.
Oh, okay. Yeah. Haesung, it's up to you. You can always go as a co-author and learn. Otherwise you
Great.
just stay in the lab and you can, it's up to you. But
Yeah.
yeah. But if anyone is going, I suggest you book now because yeah, everything is going up. I think Dr. Tegon and a lot of mentors are coming. I think our undergrad students are going. Yeah, so we'll see. Okay. Song, anything else?
Yeah, I for the graph projection PTM project that I'm gonna start working with Dr. Wongi, I have all the numbers and everything, but I wanted to redefine what graph projection would entail, like acute, chronic, because
Sure.
I gathered more details and it created a lot more confusion. So would you like me to discuss this with you, or should I just discuss with Dr. Wonki?
Discuss it with Dr. Wu first and figure out amongst you, and then bring it to me so that we can
Okay.
finalize the way we're gonna analyze. Yeah,
Okay.
yeah.
And then DLT for cancer, I'll reduce something. There was one thing I missed, but yeah, and then I'll discuss
Yeah,
with Dr.
and
Wonki as well.
the best way is asking Dr. Chian, or even you can ask Dr. Chisang, what, figure out what they exactly did. And if you're emailing them, you can CC me so that they know I'm involved. Yeah, yeah. But I think that question is important and people are going to ask PTM questions. Because I think we have just the overall survival and recurrence data in the published paper. Yeah, okay. So yeah, figure that out and just let us know in your next journal club.
And then for the last trial, the medical writer, Amarante, I don't know how to pronounce
Yeah,
her name,
medical
but
writer.
remember how we asked her to bring up any questions in advance of the meeting?
Yeah.
She hasn't responded yet, so I think the meeting is on the 31st, so we.
Oh, didn't they say like the purpose of the meeting is to discuss those questions? So until that meeting happens, she won't know what kind of questions will be raised.
But that doesn't make any sense. So the whole purpose is ASAP, let's get the protocol ready for everything. So Liam, can you call her? Just call her and say, we don't want to just sit and wait for you to start the conversation in 2 weeks. We want to know what your questions are and address it and be done with it. And really finish the protocol ASAP because we don't want to waste time any further. And if you want to talk about the protocol tomorrow, we'll be able to talk about the protocol tomorrow. We just don't want you to do nothing and just look at the protocol for the first time and generate questions on that meeting. You understand? We want to be able to move on and address anything that could be addressed through email. It's not the writer's job. They're not approving anything. They're helpers. Their job is to help write the protocol, so that everything moves faster. They're
So-
not yeah, go ahead.
So do you want to ask for the writer's questions to kind of polish the protocol, or are we trying to get the questions from the committee?
What committee are you talking about?
The SRC, the Scientific Review Committee.
I think it's from the medical writer because she did say that there needs to be significant revisions to be made in the protocol. And so Dr. Chae just wanted to clarify, like, what exactly are those revisions? What questions do you have?
Yeah. What is the significant change that needs to be made? I mean, we can't sit and wait for 2 weeks to hear those questions. Just send those questions to us in email. We'll fix it. But more than that, just call. I feel like we'll call or visit her. She's in the Arcus building in room 12th floor. So just go and meet with her, sit down next to her. What is it that you want us to fix? Tell us. Liam or Hesong, I'll leave it up to you guys. So I don't want to sit. SRC would I think, review the full protocol once it's ready, right? Did they review our protocol already, or where are we in SRC?
No, it seems like here, can I just show you this
Yeah.
email that Ashley sent me? I think I missed it, but it was on January 10th. Like previously I had asked Amarante if she could bring up any questions in advance, and then Ashley replied instead of Amarante. She said, many people will be reviewing the protocol. Like she won't have those list of questions ahead of time, as the attendees themselves will bring questions for a roundtable discussion. And she'll do some edits herself. She may have some questions for me, but she will leave. Yeah, so it seems like she may, like, it's her choice to bring up questions, but in the end, we want like a roundtable discussion.
So this is a sim. This is more like a sit down and talk about the trial type of thing. Okay, is this a Zoom meeting or is this a in-person meeting?
It's a Zoom, it's
It's
hybrid.
hybrid.
Hybrid?
Yes. So there is an invite for the 31st, 2 p.m. to 4 p.m. Location is Arky's 12th floor, room TBD/hybrid.
Okay, so Liam, Hesong, myself will be there in person. SIM is in person. Is it what day is it?
31st, it's a Wednesday.
Okay. Okay, so just respond, yes, we understand, we'll be there in person. And say, you know, apart from the actual meeting, if there is any, you know, edits that Amaranthi is making, and if she has any questions, yeah, please let us know so we can get ready from our perspective. So whatever question Amaranthi has that she is willing to edit herself, we're happy to work with her in a one-to-one basis until that meeting. But we also understand there will be other members that will give us input on that day in person. So okay, let's just leave it there. And other than that, does this meeting has to happen first in order to go to SRC? Or what is the
Yes.
process? Okay. So this is first and then SRC. What about IRB? Do we have the consent form ready? Or are we waiting? Where is the consent form?
I believe weren't we waiting on I think we're waiting on the drug insert information, and they said Akizo says they don't typically provide it unless we have a protocol. So I think we have to wait for the final protocol.
Okay. The consent form doesn't have to wait for the final protocol. So I think just work with two companies so that they agree on the consent form.
Mhm.
And if they agree, then we will submit the protocol and the consent form to the IRB. So just make sure that happens in parallel.
Sure.
So let me share this. This is the last point of contact. with the Akizo team. They asked for the purpose not provided until the agreement is executed. This drug has never been tested in the US. Therefore, the ICF will not help in the US studies. We also want to know the status of the agreements. And I said unit team requested the information.
So I'm a little confused about. So Liam, did you know about this collaborate? Three-way CD variation is done, but do we need NU and Akizo Bio, the separate research agreement?
I think there's something in the books. I'll double check. I thought it was done.
Not provided until the collaboration. Collaboration. So what do they mean by collaboration agreement? And I don't know if they sent us any document.
Yeah, I'll look into it.
Okay. I gotta go, but I know. Yeah, Liam, I know you have some presentation, so if we have time in the afternoon, we'll reconvene. But let's I don't know. Let's just leave it. I'll just leave it as pause. Yeah, pause and